Hello, everyone. Good morning. Well, at least it's morning for me still. If it's afternoon for you, good afternoon. And welcome. This is session 5 and our final session of our Tickborne Boot Camp. Remember, you're all in listening mode. If you have questions, go ahead and pop them over in the comments section. I will get to them at the end. I see we kind of have some already in there, and I will get to those at the end. So let's go ahead and get started. You guys are with me today. We had some great guest speakers before. I really felt like we learned a lot from Dr. Hinchy, Dr. Sommer, and Dr. Salt. All different approaches to Lyme and tick-borne infections, different associations of, the immune system sequela, the autoimmune encephalopathy, naturopathic approaches. So we really have had a great bit of information. Today, we are going to be talking about a little bit of a recap and some case workups, the complexity of Lyme disease, kind of that importance of pretest probability. I'm going to show you a variety of lab presentations because in this type of work, when we're dealing with labs that are in the gray space, right, when there are lots of different ways that a lab can present based on the clinical presentation of the patient and what else is going on, it's helpful just to see a lot of labs. So I wanted you to see a variety of kind of how they can present, and that helps us to really solidify in our brains how to best utilize this type of indirect test, right? We're looking at the immune system's response to an organism that's hijacking the immune system. So of course, there's just going to be a lot of nuances there. So we're going to go through a variety of lab presentations. I'm going to share with you my 4 pillars of complex patient care. I know Dr. Hinchy shared her 10 Bs, and Dr. Sommer had kind of a 10-step approach. Dr. Salt really talked about weighing if it was, infection versus autoimmune sequela or both, and kind of how that goes together. And I have my own, these 4 pillars that I call of complex patient care. And I hope that by looking at 4 different providers' ways of treating a complex patient, maybe you will take from each of those and develop kind of your own pattern. It's more than a protocol, right? It's not just putting somebody on a protocol of supplements, but it's really about how do we think about their case and how do we pull it all together. And then at the end, I'm going to talk about what's on the horizon for tick-borne testing because cases are so complex, we want to be able to continue to offer testing to providers that is going to deal with the complexity of the cases of the patient. Not just is there a pathogen, but what is happening with the immune system. So I'm going to share just a little bit of insight on kind of what's on the horizon. So it's a little bit of a hodgepodge today, but we will get through all of it. All right, so some of you were very new to tick-borne testing when you started this boot camp. Some of you maybe are Lyme literate and have been doing this for a while, but I will tell you that having the kind of this slope, this Dunning-Kruger effect, is very common. That at first we think we kind of know everything, and then all of a sudden we think, oh my gosh, we know nothing. And then we spend most of our careers here on this slope where I always find I kind of backslide sometimes. Sometimes patients will come in and I'm like, whoa, it throws me for a loop. Do I really know as much as I know? And we need to really peel it back. So don't get discouraged if you feel like you were drinking from a fire hose, you got a lot of information, and now we don't know what to do with it. Just start, and you will stay on this slope here. Many people don't get to full mastery. Not everyone's going to be Dr. Horowitz, but you can really treat a lot of patients and be really a great provider in the Lyme community when you are just working in this general slope and just being, having good humility and knowing that we don't know everything, but we're going to be there to listen to our patients and be able to help them. So just stay the course. And even if you don't want to treat Lyme, if you still want to test for it to help patients then navigate and get to the right person, that's a great way to deal with this type of complex care as well. Okay, so because there's so much complexity, I just want to make sure that you have the resources of the research from and the clinical validation of the tick-borne diseases, all of the Lyme and co-infections on the microchip. This really arms you with the ability of knowing when you test a patient that you are getting accurate results that have high sensitivity, high specificity, and high reproducibility, so that then we can make the most accurate diagnosis as we clinically correlate. So having, scanning this QR code, having this preprint research available, because patients will ask you about it. Patients know, they hear when they're in those Lyme blogs about testing, validity of testing. So it's helpful to have these pieces with you. If you want, this is in our white paper. Now, the white paper is also in the portal, but this chart is on page 3, this comparison table, and it compares the microchip proprietary array to the ELISA, the Western blot, and the immunoblot, just point by point. This is the first time this has ever been done. It has been asked for years. And so please, have this as part of your white paper that you can go through. Most of this information is in the week 1 session that we did, but sometimes we don't want to pull out a whole PowerPoint deck. And this is a nice 1-pager to be able to really compare why you would do one testing over the other and what are some of the limitations and strengths of different testing. Remember that we have all of the different markers, full analyte offerings for indirect and direct offerings. And so you can choose Tickborne 1.0, Tickborne 2.0, or you can order individual columns for the most comprehensive testing. And once you have the most comprehensive testing, then we know our patients are not falling through the cracks with getting a negative test if they were maybe positive for something that wasn't tested. So we want to try and test as many pathogens as possible. So just a little recap, why is Lyme so complex, right? Well, first of all, it's controversial for various different reasons. And there's some great documentaries that are out right now. It's Lyme Awareness Month, so there's a lot of information out there. So the topic of tick-borne disease and Lyme disease is controversial, which already is going to lead to the complexity from the patient's perspective. Then we have less than 50% of patients remembering a tick bite. Nymphs can transmit Lyme and they're the size of a poppy seed. So they may not see this large engorged tick that's on their skin, especially if they're not doing regular, tick checks, if they're not used to that or not in an area that they're, prone to being able to test that every time they come inside. Less than 50% of patients are going to develop that bullseye rash. Now, if they develop the bullseye rash, it is absolutely diagnostic of Lyme, but less than 50% are going to have that bullseye rash. And even if they have the bullseye rash and it's diagnostic, we don't know about their co-infections. And so therefore testing is still warranted. If they had standard of care antibiotics right away, we could have delayed onset of some of the serological markers. If we don't get that early diagnosis, then they could have delayed standard of care antibiotics, which could then lead them to chronic Lyme, which is then more complex and more difficult to treat. And, Dr. Salt talked about that 10 to 20% of patients who are going to continue on with symptoms even after the standard of care of antibiotic treatment. Some of that is because, from ILADS, the standard of care antibiotic treatment is not long enough. Others of that is because we just have patients whose terrains are more susceptible to them having persistent infections and or autoimmune sequelae. Then, it's going to take patients lots of years to get diagnosis. and get a proper diagnosis. And ultimately, it becomes a clinical diagnosis. Providers need to have the abundance of critical thinking when we use the labs more as a confirmatory tool to what we're already thinking. And that's what we're going to walk through today through our pretest probability. So because of this, look, Lyme is the great imitator. Look at these post-treatment Lyme disease patients versus controls. Most of these symptoms are pretty non-specific: fatigue, joint pain, focusing or concentrating problems, memory problems, muscle pain, all those things. Let me make this a little bit bigger, see if we can get there. There are word finding issues, sleep issues. So we tend to have a lot of patients who are going to have these, whether or not they have Lyme disease. So it's something to keep in mind that we are going to really have to do a lot of digging for these patients. So let's talk about that pretest probability. So we want to take a very detailed driven and complete history. And there are some tools that you can use to be able to help kind of guide your questioning here. But do talk to them about their geographical residence history, travel history. Although we do know that ticks are in all 50 states, if they are living in an endemic area, that already puts it higher on the list. Known exposures of ticks, but also other biting vectors. We covered that a couple different times with some of the other presenters as well. The onset of symptoms, if they had a summertime flu, that should start to move that up to the top of the list. We don't often get flus in the middle of the summer. Also talking to them about the time prior to when they've started to get ill. When was the last time they felt good? That's a pretty common question, from the IFM. Was there an infection? Did they have COVID? Do they think they have long COVID? If they think they have long COVID, maybe it's a reactivation of a Lyme or other viruses. Were there stressful events in their life? And so we want to really get some ideas on that. And then what's the nature of the symptoms? Was it gradual or sudden? If they had a summer flu and then they've never felt good since, like, we need to start moving tick-borne diseases up higher in our differentials. And then we're just reviewing a lot of those classic symptoms. And you can get those classic symptom lists for Lyme as well as the co-infections in some various books that I'm going to point out at the end. Utilizing that MSIDS questionnaire. So this is the Richard Horowitz tool, the multi-system infectious disease syndrome. And this questionnaire is available in your provider portal. This will guide through various sections between symptoms, geographic, onset. So a lot of those categories that I just went through, you can utilize the MSIDS questionnaire to be able to guide those questions with your patients, and then be able to populate out a score that can tell you if they are, if it's probable or possible or not likely. If they had a score 0 to 24, then tick-borne disease is not likely, and maybe we need to start looking for something else, looking for their toxic burden, looking for hormonal dysregulation or something of that nature, versus if they have a score 45 to 62 and tick-borne illness is probable, then we're going to want to start looking at doing some further testing as far as tick-borne diseases go. So this is a great tool. Please download that from your portal. Always remember your differential diagnosis of migratory pain. Migratory joint pain is classic for Lyme. There are only a handful of other things that have migratory pain. They are listed here. This is directly from Dr. Horowitz's MSIDS differential diagnosis for migratory pain out of his book. And it gives testing for the other conditions that cause migratory pain so you can rule them out. Lyme disease is the only disease with migratory nerve pain. So thinking of your differential diagnosis of joint pain versus nerve pain, and if it's migrating, this is a great slide to keep track of so that you can rule out and rule in any other types of conditions that might be causing some migratory pain for your patient. So this is the test we all want to see, right? This is the slam dunk test. This is it's all positive. The CDC is positive. The IgM is positive, IgG is positive, the alternative Lyme is positive. Like we've got red all over the place like a Christmas tree. I will tell you, I have seen this less than a handful of times in my career. Now, I also live in Colorado and I'm a functional medicine provider, so I'm not treating acute Lyme. Most of the time I'm treating chronic Lyme. And so the acute presentation, like this testing, is not usually what you are going to see if you are running a traditional kind of functional medicine office. Now, if you have an acute care or an urgent care arm of your practice and you are in an endemic area, and I know that there are providers on here that do fit into that type of practice where maybe you are seeing patients in the acute right after a tick bite. You may see a presentation like this, but don't expect it. And so the more that you're testing, just because it's not all lit up like a Christmas tree and not positives all over the place, does not mean that the patient doesn't have Lyme. It just means it's not acute Lyme. So I wanted you to see what a very acute Lyme presentation for Borrelia burgdorferi looks like, so that then we know, okay, that's acute Lyme, but what is it that I'm going to see that's maybe in that more chronic Lyme presentation? So this is going to be a more common chronic presentation. We're going to have some persistent IgMs that are going to be moderate, but not enough to get us to a criteria for either CDC or alternative. And then we have kind of a combination of yellows and reds in our IgG that are going to be in the right combination to get us to the alternative Lyme criteria. We still might be negative for our CDC criteria. Now, based on the patient's clinical presentation, this is absolutely positive Lyme. It just doesn't look like this test, okay? But it shouldn't be dismissed in saying, oh, well, the CDC is negative, so we're not going to do anything about this. This patient is still a positive Lyme case, obviously, after we do our clinical correlation. This is a very common presentation, and this box here, this red one, alternative Lyme criteria, that's the box that I go for the most, because the alternative Lyme criteria with the IgG and the immunochip is 100% sensitive and 95% specific. So I can be very confident that if I have a positive in this red box, that is what I need to go forth with as far as making a diagnosis for my patient. I did put in this little flow chart of the alternative criteria again for that increased sensitivity. You do also have a great schematic of this in your portal so that you can differentiate between CDC criteria, alternative criteria for IgM versus IgG, since it is very common that you will get a negative and a positive that populates on the same test, trying to determine which one that we go off of. And you want to really read off of the alternative criteria in the IgG. If the patient is chronic, that's the column and that's the box. That's going to be the one that we should really draw to first. Always remembering also our bingo bands. I think those were mentioned by one of our guest speakers as well. Wanted to bring in the actual slide from Dr. Richard Horowitz. If you have any of these bands positive, the 23 on our test, it's 23-25, the 31, the 34, 39, or the 83-93. These are very specific for Lyme. So you should like spidey senses going up that we need to be really cautious and be considering Lyme disease if we see any of these bands coming through on our testing. So it might look like this. This person is positive for both IgM and IgG. The things that really stick out to me, in addition to them being positive, is also this band 31 that's high. That is highly specific for Lyme. And then we also have their 23-25, which is above the control. It's in the moderate for IgG. So in addition to meeting the criteria for IgM and IgG, we also have highly specific bingo bands. the bands that I'm going to really be watching, and a goal for presentation or goal for treatment here is getting some seroconversion, particularly of that band 31 over into the IgG, knowing that the immune system is kind of dealing with that exposure of that part of the spirochete. We also want to have considerations for C6 peptide and VLSE1. Those are also highly specific, and C6 peptide is being looked at in this particular article, the Journal of Microbiological Methods, as a standalone serological marker to monitor Lyme. So go ahead, make sure you pull these articles out, but a lot of providers will really be looking at that C6 peptide in addition to that VLSE1. So you might have a Lyme presentation that looks like this. So look, we've got all negative criterias down here. But look at this, VLSE1 is above 30. We also have a C6 peptide, and the only other band that's populating up is a bingo band. These are 3 highly specific bands for Lyme disease. So although we may not be able to say it's all, criteria positive, it may be warranted to do some digging for this patient of, how is their total immune system function? Were they able to mount a full immune system response? Could they have had Lyme in the past that's in that autoimmune sequela now that we need to deal with? Do they have other complicating factors, mycotoxins or whatnot, that are making it so that we're not quite meeting the criteria, but Lyme is still a component of their picture? So that's where the critical thinking comes in. And it's not just a quick glance, oh, it says negative and moving on. You need to be able to kind of pull out these really important little pieces of what these little bands mean and what these bingo bands and highly specific bands mean. And what about this patient? Initially, we would look at this and say, wow, this is great. It's all green. Okay. Again, just like that acute Lyme presentation that I showed early on, we don't see that very often, but we also don't normally see these all green tests. One, it's because we have pretest probability. We are only testing people who have, higher MSIDS questionnaires, who have had, have lived in geographic areas where it makes sense or their clinical picture makes sense. But if you are testing a patient who clinically you already think could have Lyme, it's in your differential, and their test comes back all green, we can celebrate if we're like, great, it's going to check the box off if we're really confident that the immune system's working well. But we probably want to look and make sure the immune system's working well. So this patient ended up having low total IgGs. They had a massive amount of immune compromise. And they were also they had been on a steroid prior to the lab testing for joint pain. One, their joint pain was so bad they needed a steroid. And 2, they hadn't disclosed that they were currently still taking a steroid at the time of testing. So in this situation, when you have an MSID score that's so high and we have an all green test, that does not compute. And we need to ask the patient, is there something else going on? We need to test their immune system, test their total immunoglobulins, and try to pull that together. And then lo and behold, this patient, once they went off their steroids, retested, we did get a positive criteria when the immune system was kind of back at a baseline. Okay, with your co-infections, please always remember, because we don't have criterias, and because most co-infections, some of them have a couple recumbent antigens, but maybe, in this situation, there's only 3 recumbent antigens, 1 whole cell sonicate. For this Bartonella, it's just a whole cell sonicate. So you may not have, you don't have all of the listings the same way you do with Borrelia or Burgdorferi. So this is where you really need to start determining, is this IgG at 13.4 clinically relevant, or is it a memory cell? We have to clinically correlate. And same is this IgG at 20.9, is that clinically relevant based on, is it actually a chronic marker? Is it a reactivation? Or is it also just a memory cell in somebody who has a robust immune system? So it is your job to look at the patient clinically and determine, how their IgGs are presenting. So here's a list of clinical correlation symptom profiles for Babesia and Bartonella. This is compiled from these 3 books down here, Dr. Nicola McFadzean, Dr. Horowitz, and Dr. Rawls. You can find various of these lists. What I have done is just really mushed them together because, sometimes it's better to have a whole list of them. And so what I will do is, like, for instance, Babesia with this 13.4. I've asked a lot of these questions at their initial intake, but when the test comes back and I see that, I may pull this sheet out and make sure that I've asked all the other questions. Maybe I didn't ask them if they had vivid or violent dreams or nightmares, and they didn't tell me because they didn't think that it was important. Maybe we didn't talk about ringing in the ears, or they didn't seem to mention their tooth or jaw pain because they were there more for their headaches. And so you want to really run through those lists anytime you have any immunoglobulins pop up, because then it can give us clues to that clinical correlation. And then always the last piece of Horowitz's MSIDS work is the 16-point framework. This is his version of kind of further laboratory workup. I like to keep this so that I can kind of check off, have I, accounted for their immune system dysfunction, their inflammation, their toxicity, possible allergies, sleep disorders. Like, these are all the things that you need to think about, and some associated labs that can be helpful to make sure that you are addressing the whole person, because ultimately it's a terrain issue, right? They were susceptible for some reason. They were in that 10% that Dr. Salt talked about that had the predisposition to be able to continue being sick even after they either had initial treatments or, their immune system could clear it initially. Okay. So that was just some lab presentations. I told you today would be a little bit of a hodgepodge. What I would like to do is go through my 4 pillars of chronic or complex care for patients. It's really about the health of the host over the strength of the bug. And hopefully this can give you some points to be able to pull together for all of your patients. So Dr. Hinchy mentioned this, but I'm going to say it one more time for everyone on and everyone in the back. No combination or amount of antibiotics is going to completely eradicate this level of infection. It's the body's immune system that must eliminate it from the body and put it into remission. So that has to do with either prescription or herbal. The goal is to shrink the infection to the amount that is manageable by the immune system. Well, what does that mean? That means we need to be also supporting the immune system and balancing the terrain and healing their gut and removing toxins and all the other things if we want proper treatment for our patients. So it's got to move beyond this constant kill protocol. I also want to just bring into light, because you will see these patients, the more you do Lyme, you will have the patients who have already been treated for Lyme for the last 5 years. They've had a PICC line, they have had massive amounts of antibiotics, and they are coming to you and they're like, I've taken more antibiotics than anybody on this earth, and I am still sick. So often these patients, these chronic Lyme disease post-treatment patients, can be the hardest ones to treat because of the damage caused to the terrain. So this 4 pillars of treating them becomes a lot about the 3 pillars that aren't the kill protocol, because we're trying to support the terrain. And so just don't think that, oh, well, maybe instead of prescription antibiotics, you just need herbal antibiotics. We need to make sure that we're taking a full system approach for these patients. So this is my 4 pillars of complex patient care. And the reason I put this little picture in here is because it's often like dancing the cha-cha with your patients. Excuse me. A little front, a little back, a little bit in this box, a little bit in that box, a little bit all over the place. So, and we need to tell our patients that they're going to be dancing the cha-cha with us for a long period of time. And Dr. Salt gave a great point of, kind of how to estimate that based on where they are on a, 1 to 0 or 0 to 10 scale. I tell my patients that it is 1 to 2 months of treatment for every year that they have been sick at a minimum. So that will already, most of the time, patients have come into you and they've been sick for a long time. So it's already going to give you a big bulk of time and that you can start to work with. Okay. All right. I popped myself back up on the screen here, but you guys can see that their little cha-cha is just going to stay under there. So let's go through some of these boxes. Now, of course, we only had an hour today, and so I'm not going to cover every single thing. And a lot of these bullet points are covered in those other 3 sessions with our guest speakers. But number 1, or box 1, is strengthen the host. So that's that immune system support and shift and compromise that Dr. Salt talked about. We're going to talk about digestion function and mitochondrial support, dealing with their detox support, their ability to methylate, how much inflammation is in their environment, how much inflammation is in their system. Do they have a good whole food anti-inflammatory diet, and what are their supplemental needs for their nutrient status? So I just pulled a couple of them out. Now, well, I'm going to remove myself here so you can see this again. If you do not want to treat Lyme, but it's in your differential and you tested for it and it came back positive, and now you're waiting to get your patient to the Lyme literate person for treatment, you can do so much good by just working in their gut. To strengthen the host, we know from functional medicine that we need to start in the gut, right? The key to health is through our gut. 1, because of the exposure of the pathogen, but also because of very often their antibiotic treatment. So if all you do is spend time in this flow chart, you are going to do a world of good for your patient, because by healing the intestinal and microbial damage, you stop a lot of this flow of, the barrier function compromise that increases that translocation of pathogens, the inflammation that ultimately makes them have decreased resistance to the disease, and kind of so on and so forth. If you can heal up here and work on their gut, you stop a lot of this flow. And consequently, over here, as far as this altered gut structure, if you can get them digesting and absorbing more, they have less malnutrition, so they have more nutrient cofactors, they can detox better, they have better endocrine systems. And so if really what you do is spend a lot of time to strengthen the host and heal and seal the gut, you will have a patient who will ultimately respond better. And maybe that's because they're waiting to go to a Lyme literate doctor for, the kind of the quote unquote kill protocol, or maybe it's because you want to do all of this foundational work first before you just blast them with, kill herbals or antibiotics again. So spend a lot of time here with your patient, do some stool testing, look at their intestinal permeability, because you can make a world of improvement just by focusing on healing and sealing the gut. You can also make a world of difference by supporting their mitochondria and the mitochondrial dysfunction that comes from the persistent pathogens as well as from the antibiotics. Often, this source of ongoing fatigue for patients, especially the ones who have been on, years of antibiotics, can come from mitochondrial dysfunction. They maybe don't have a persistent pathogen anymore, but it's more about the damage that has been done to the terrain that gives them a lot of fatigue and loss of endurance and loss of ability to be able to just really continue throughout their day. That ongoing mitochondrial dysfunction is going to cause increased oxidative stress. If you think about the mitochondria like a car, in a new car, when you are driving it, it has exhaust that's coming out, but you can't see the exhaust. You can not smell the exhaust. There's debris that's, there's exhaust that's coming out, but it's pretty clean burning. versus the old farm truck that's got the big black smoke that's coming out of the tailpipe, right? So we have that both cars may be going 20 miles an hour, but one has a lot more debris. Those dysregulated mitochondria have a lot more ROSs coming out, which then ultimately cause them to be more damaged and have more dysfunction, and it can all pass along. So you want to make sure that you're addressing for their mitochondrial function. Now, there's no direct lab testing for mitochondrial function. I say that with a little bit of a caveat. There was a lab at IHS in February that I noticed, but it was really only testing one portion, and it was like $1,200. So the utility, our providers and patients really going to be able to do that? Probably not. But you might want to just assume mitochondrial dysfunction and support mitochondrial function for your patients when they are coming in with either having been on antibiotics or if we know they have a persistent pathogen or both. Okay, so next you want to reduce those stressors. Now, Dr. Salt talked a lot about toxicity. He showed you a toxic burden test. I'm going to talk a little bit more about oxidative stress, but really looking at all the different ways that stressors could be impacting the system because it's a terrain issue. Do they have adequate nutrition and nutrient status? Are there opportunistic infections? What's happening with their drainage pathways? Do they have a congested liver or lymph? What else is going on that could be increasing stress on the system? So this is oxidative stress. We have external sources, which are, our environment, pesticides, heavy metals, phthalates, poor diets, smoking, UV radiation, alcohol, those types of things. So there's lots of different ways for diagnostic options of kind of those external sources of the toxic burden and antioxidant status of our patients, diet, and that type of thing. There's also the internal sources of our ROSs. Our body does create ROSs in the example I just gave you of the two different cars. Our mitochondrial dysfunction can very much cause system dysfunction. And then our antioxidant defense system can have, these enzymes are controlled by genetics, our genetic SNPs and the nutrigenetics. So we want to be able to evaluate how open those pathways are. Now, Vibrant just recently came out with our oxidative stress testing, where you can do the direct measure of damaged products, but you can also test those nutrigenetic SNPs for the antioxidant defense system. So evaluating not only the presence of pathogen in the immune system function, but also the collateral damage of the oxidative stress helps you to both identify the pinball in the machine and the damage that the pinball is doing in the machine. Okay, so if it's banging around and it's causing a lot of collateral damage, that's what you would test for your oxidative stress, in addition to understanding, how many pinballs that you maybe have there as well. All right, so creating balance. I say that this is often the forgotten step because this is the one that sometimes we don't think about, right? We don't think about the psychological support. We don't think about the cell danger response or the vagus nerve, the effects that was happening from the medication, the psychological effects that are really happening here. So this section, I really want you to listen to understand your patients. Most patients, I would say 99% of patients, if they are dealing with chronic Lyme, chronic mold, these chronic complex patients, they need psychological support, not because they are crazy and not because it is all in their head, but because most likely they have been dismissed from the medical community and their family and their friends because they can't explain what is going on to them. They appear to look normal, but they can't function normally. This journey with chronic Lyme can really cause a form of PTSD that's caused through medical trauma. So you want to stop and not just be about the negative, the positive, I'm treating this oxidative stress and I'm giving you this antimicrobial because of this positive. We need to really help treat the whole patient and how their body is responding. I put a couple of my favorite books up there. The Body Keeps Score assessing the healing power of the vagus nerve. The Lady's Handbook for Her Mysterious Illness. This is written from a patient's perspective. I think it should be required reading at all medical schools so that providers can really get in the headspace of the patients with these kind of mysterious illnesses and chronic illnesses, and how to address them. And I am guilty. I used to, there were people I would see in my schedule and I would be like, oh my gosh, okay, like drainage, like energy draining, like I don't want to deal with it. By the end of, dealing with Lyme in the last couple of years of my practice, majority of my patients are all, would be kind of cut from that cloth, but it doesn't, don't look at it the same way. I have a different perspective, and a lot of it comes from this book, which actually was given to me by a patient maybe 5 years ago. And once I read it, I was like, oh, okay, we really need to kind of do this, listen to understand. Okay, so now we actually get to the kill protocol. All three of those other things, I truly believe, should be done first. Most of the time, the patient has been dealing with this persistent infection for years by the time they come in to see me. So taking a little step back and doing those other three sections first, prior to jumping into more of a kill protocol, tends to make them respond better in the end. Now, when you get to the kill protocol, it's best to really do kind of a multi-directional approach. It's not, they're sick for a reason. It's not just a one-time like, hey, I'm just going to give you cryptoleptis and it's going to like bang it, be out of here and like you're going to move on and be great. So you need to make sure that's through proper testing, make sure that we're addressing for bacteria, viruses, parasites, fungus. Those all have different components for antimicrobials that we need. If you need antibiotics, evaluate for that. But herbals and botanicals can do a beautiful job in these chronic patients. Make sure we're addressing for biofilms. I will forever remember Dr. Salt's presentation, or little analogy of the Jell-O with the fruit cocktail in it. You've got to break up that Jell-O so that you can get to the fruit in the fruit cocktail to be able to really eradicate it. Bring in other types of therapy, things like hyperbaric oxygen, IV ozone, SOT, which was mentioned in one of the other sessions as well. Homeopathics have great options, but you need to hit this from various different levels. It's not going to be a single antimicrobial that's going to do it. I like this idea, and this was actually written up from Johns Hopkins, of evaluating natural and botanical medicines against doxy. Think of it more like this. When you use herbals and botanicals, you're more of a sniper and a farmer working together. The sniper is killing the pathogen while the farmer is dealing with the terrain, keeping the inflammation low, balancing the immune system. There's these system approaches that the botanicals have that help to work in synergy to help the patient heal, rather than a prescription antibiotic that just is like an atomic bomb that just comes in and kills everything. That's not to say that the acute patient that we saw earlier doesn't need the antibiotics. They absolutely do. But the chronic patient who's been sick for a long time, think more of sniper and farmer working together rather than just coming in with more and more atomic bombs. Here's some of my favorite protocols. I know everybody asks for protocols. This is what you can bring in as far, but I want you to incorporate the ones that work for you, right? So a lot of them are going to have a lot of the same key ingredients, whether it's Japanese knotweed or whether it's cryptoleptis or cat's claw, in different combinations. These are all the herbal ones. But pick the one that really resonates with you, but also know that patients are different, and you might, someone who might do really well on a Zang protocol, there might be somebody else who does really well on a Cowden protocol. So keep that idea, and there's lots of different options there and some different Google documents on their protocols. Alrighty, so what's on the horizon? This is our last little section for today. The horizon for tick-borne testing. Well, the big news is that we want to further evaluate at a peptide level, is it a persistent pathogen or is it an autoimmune sequela? So Vibrant has, we've really improved the testing landscape with this peptide level testing. most of the biological interactions that are happening at this peptide level and not necessarily at the protein as a whole, which is why it's so important and so valuable to be able to use a peptide microarray in an immunochip to be able to test at the peptide level. So we were able to do that in celiac disease with wheat sensitivity and really identifying that detection with like rheumatoid arthritis and other diseases. So what we are going to do, I keep needing to kind of remove myself there. There we go. So when we have this insight into antibody recognition, immune system responses, we can start to see overlap with other diseases, including molecular mimicry, meaning certain parts of the spirochete, meaning like band 31 or a certain surface protein, is similar to the sequences that are our own human tissue. And through molecular mimicry, as the body is attacking that portion of the spirochete, it could consequently attack certain tissues in your body, and that becomes an autoimmune sequela. Okay, so what's next? What's next is that we're going to be able to test the overlap between the pathogen and your immune system going after the pathogen itself and your immune system going after some of these other sequences of peptides that are that is going to be more of an autoimmune sequela in 3 particular categories: arthritis, carditis, and neuroborreliosis. So we're going to be able to really help you differentiate, like, do I have a pathogen only and no immune system autoimmune sequela? Do I have a pathogen and autoimmune sequela? Or do I not have a pathogen, but I still have autoimmune sequela? And so now my treatment is going to be different because I'm not even going to employ the kill protocol at all. And I'm only going to be working on dealing with the immune system and the autoimmunity that was triggered by the initial pathogen. So this is really exciting to be able to break those things apart. I went ahead and listed them in here. They're going to be in the slides that you guys are going to get copies of. But just know that within Lyme arthritis, there are several different antigens that there are several different peptides that are going to have cross-reactivity with these different antigens from the spirochete, particularly OSPA or band 31. Band 31 has high amounts of cross-reactivity into the world of autoimmunity, and we've known that for a long time. But now, because of the protein or the peptide microarray, we're able to actually test for this to be able to see, is there cross-reactivity that can explain the immune response that's happening in Lyme arthritis. So we have 6 in Lyme arthritis, those 3 and these 3 that are all going to be helpful for us to determine the autoimmune sequela that's happening in the arthritic realm. We've got 2 that are going to come from Lyme carditis. So the Lyme spirochete often is going to acquire lipid molecules, and therefore we're going to see some autoantibodies that the body makes against its own host lipoproteins. And this can be really observed through Lyme carditis as our patients present with cardiovascular presentation. And then the cardiac myosin is going to have this role in damage of inflammation of the heart as it was triggered off initially from the pathogen. We also are going to have 3 markers for Lyme neuroborreliosis with cross-reactivity for some of our other Borrelia species, Lyme, the Borrelia afzelii. The band 23 to 25 has some cross-reactivity that is triggering off for the potentially associated with neuroborreliosis. GM1, which some of you might be familiar with from our neural zoomer, we've known for a long time its association with Pants pandas. Also has high association with neuroborreliosis. So we put that on, that's going to be coming down the pipe. And then we also have another marker that has association with the 23-25 on Afzelii. Afzelii, whenever we would see it, we would tend to see patients, when they had IgMs and IgGs with Afzelii, that they tended to have higher amounts of neurological involvement. And now we know why, because of this autoimmune response that's happening to these self autoantigens. So what's the clinical utility of testing Lyme autoimmunity? It's really to tease out, what are we looking at? Are we looking at a persistent pathogen? Are we looking at an autoimmune sequela? Are we looking at both? So you can help to determine the autoimmune cascade that was linked to the initial pathogen. You can start to, if your pathogen testing is within normal limits, you can see kind of what is the immune system's ongoing contribution in those three categories. But then you can also monitor their progression of autoimmunity, and you can monitor your treatment action items that you've done, or your treatment interventions in the realm of autoimmunity. Are they calming down and no longer attacking self as you've employed a lot of your autoimmune tactics? So there's some really great and really helpful functional utility when we start to widen the lens of how we're looking and testing tick-borne diseases. All right, that is what I have for you today. I'm going to bring myself back here up on the stage. Thank you so much for everyone to join. Really enjoyed being with you over these last 5 weeks. I'm going to go ahead and pop over into the questions here, and we will see how we're doing. Okay, so let's see. All right, so we have a question about receiving a certificate for attending all 5 classes. I'm going to check on that for you. I am not sure what is all sent out. I do know after each session, you do get a copy of the recording and the slides. I'm not sure if there's a completion certificate, but I will work on figuring that out. Let's see here. Yes, all sessions are going to be recorded. Okay, so here we have a question. So what was the cutoff value for calculating the sensitivity and specificity? So it would be anything in the moderate or high. So yes, so above, so 10.1 to 20 is moderate, and 20.1 and above is high. So anything in either one, anything that's outside of within the normal limit, so anything that's not green, any yellows or reds, so above 10.1, would be calculated in to determine the sensitivity and specificity of that publication that we had up initially. Okay, symptom assessment tool, the MSIDS. So that it should be in your provider portal. I'm going to make a note here that I'm going to have that sent out when we send out the slides and the recording. So at least everybody here will get a copy of it, or anyone who is registered. And then if you, it should be in your provider portal under Tickborne. In that folder, that's going to be where MSIDS handout is going to be. All right, so going back to when we talked about mitochondrial health, yes, the organic acids test is a great way to indirectly assess for the mitochondrial health. So yes, in an indirect method, you absolutely can do that. The one test I was talking about that I saw that had a booth at IHS, they were looking at more of a direct method, and I actually don't remember the name of the test or which markers they were looking at, but it will be the but that is the only one that I know about. So yes, when we're assessing mitochondrial health, currently an organic acid test is probably going to be your best option for indirect. And then also looking at oxidative stress. It can be assumed that the higher amount of oxidative stress you have, the more damage that you are going to get to your mitochondria, because they're highly susceptible to increased amounts of ROSs. And that can also give us some clues on how much we need to protect the mitochondria. Okay. Okay, so let's see here. So is it more or less advantageous to clear all toxicities at once? There's a more appropriate order, killing or same with killing and binding the pathogens. Okay, so Of course, every patient is different. However, I will say from what I have seen in my clinical experience is that if somebody has mold, you have to clear that first. The mold is going to always perpetuate this immune system dysfunction that will make it very hard to kill other pathogens. It also makes the terrain susceptible or hospitable for those pathogens to reactivate and be problematic. So if I'm thinking of just kind of big picture, mold is going to be something that I'm going to clear first. And then if we're dealing with just tick-borne pathogens, the one that stands out with the highest amount of clinical correlation and or the IgMs are the ones I go after first, and then I start layering in from there. So that's going to be different for every patient. If they don't have any IgMs, I just go off the clinical correlation. If they have IgMs and clinical correlation, I just kind of, best guess based on the patient that's sitting in front of you. But that clinical correlation and active immune system response should help to kind of guide out where you're at. And then because most of these patients are pretty sensitive, I don't come in and try and clear everything at once. I will kind of develop my plan of the things that I'm going to work to kill as once they have their terrain supported and I have addressed those other 3 boxes, then I come in kind of one at a time and I layer them in. It may get to a point where they're on antimicrobials for various different things, right? For bacteria, they might have some antifungals. They might also have some antivirals in there all at the same time, but they have been layered in there to make sure that their herxing wasn't too bad for them to handle. And then I also agree with Dr. Salt in that idea of, a certain number of weeks on and then some rest time. He does 4 weeks on, 2 weeks off. And that tends to work really well too, to kind of start to give them some rest time in their treatment. Okay. Let's see here. All right, last question. We've got some questions about desk bios. Yes, I do love desk bios as far as homeopathics. I agree. It wasn't included on the list. There's a lot of other great companies. Desk bios is great. Biobotanical Research, the company that makes biocidin, is great. Orthomolecular, they have a new Lyme line out. Those are great. So just because I didn't put them there doesn't mean that they're not wonderful. I just kind of put the most common kind of complete protocols up there rather than just all companies. But Desk Bios is absolutely a great homeopathic and a nice way to add some multidirectional kill protocol. So if you're doing herbals, you might also want to add some homeopathics. If you're doing ozone, you might want to also do some homeopathics to be able to really get to the root of that. All right. And last question, somebody asked, anaplasma, did we talk about it? We did not talk about that today. There are some other webinars in your portal that do go through co-infections that includes a deep dive into anaplasma, one by Casey Kelly, Dr. Casey Kelly. So go ahead and check that out. There's also a great write-up in Nicola McFadzean's book on anaplasma and Ehrlichia. And those, she has some really great symptom profiles and information on that as well. Those are tested on the Vibrant testing. And then you can kind of do your deep dive into their symptom profiles in Dr. Nicola McFadzean's book, which is the Beginner's Guide to Lyme Disease, which I still use to this day. So very good. Well, thank you everyone for all of your engagement today and your engagement over the last 5 weeks. It's been a pleasure spending this time with you. And please do not hesitate to reach out to the clinical team when you have tests that you are running and you want to be able to go over them because they really are complex and it's helpful to have another set of eyes on there. So thank you, everyone. You have a great day.